Welcome and good afternoon and good evening to those of you who are joining us on the East Coast. Welcome again to the 6th annual Touro University California Social Justice and Public Health Series hosted by the Public Health Program. My name is Gail Cummings and I am the Program Director for the Public Health Program here at TUC. I will be moderating today's session along with Professor Deirdre Wilson. This year's series entitled Public Health in Times of Pandemics will focus on two public health crises, COVID-19 and the impact of police violence, both of which have collided into a devastating pandemic tandem, both of which are disproportionately impacting Black, Indigenous, and other peoples of color. To help us understand and untangle the root causes, implications, intersections, and solutions of these two public health crises, we are continuing our 6-part series, which launched last week with Deputy U.S. Surgeon General Erica Swartz and Dr. Ben Gupta, who spoke about the clinical impacts of COVID-19. We are extremely privileged because today's speaker, Dr. Anthony Iton, who joined the series in 2019, will be speaking for a second time. As our landscape has changed in dramatic ways, in obvious ways as a result of the pandemic, but the root causes that he addressed in 2017 are now gaining greater clarity, really, for the rest of the country to see and understand. Before we begin today's session, like we always do at our series, we want to acknowledge that the Touro University, California is on a site of the traditional land of the coastal Miwoks, the Susunis, and other Petuan peoples, past, present, and honor with gratitude the land itself and the people who have stewarded it throughout the generations. This calls us to commit to continuing to learn how to be better stewards of the land we inhabit as well. Thank you. And now I'd like to turn it over to Professor Deirdre Wilson, Chair of the Community Health for Action Concentration.
Good evening, everyone, and welcome and thank you again for participating in this year's Social Justice Speaker Series. As this is also a class, we are offering continuing education units, continuing medical education units. So for those of you who are interested, please log on to the continuing education website, and the code that's available is here. I'll also place this code in the chat function. After Dr. Iton presents this evening, there will be an opportunity for questions and answers. Please submit all of your questions within the Q&A function in the webinar, and we'll do our best to have all of those questions answered. Some of the questions may be condensed or collapsed if there are multiple questions. So with that, I'd like to introduce Dr. Anthony Iton. Anthony Iton is the Senior Vice President for Healthy Communities at the California Endowment, a private statewide health foundation whose mission is to expand access to affordable, quality health care for underserved individuals and communities, and to promote fundamental improvements in the health status of all Californians. Dr. Iton oversees the implementation of Building Healthy Communities, BHC, the foundation's 10-year, billion-dollar, 14-site, multi-sectoral, place-based initiative designed to improve health status of 1 million low-income Californians. Prior to that, Dr. Iton served for 7 years as the Alameda County Health Officer and subsequently Public Health Director, where he oversaw an agency with a focus on preventing communicable disease, outbreaks, reducing the burden of chronic disease and obesity, and managing the county's preparedness for biological terrorism. Dr. Iton's primary interest is the health of disadvantaged populations and the contributions of race, class, wealth, education, geography, and employment to health status. He has asserted that in every public health area of endeavor, be it immunization, chronic disease, HIV, AIDS, STDs, obesity, or even disaster preparedness, public health practitioners must recognize that they are confronted with the enduring consequences of structural poverty, institutional racism, and other forms of systemic injustice. He further asserts that the only sustainable approach to eliminating health inequities is through the design of intensive, multi-sectoral, place-based interventions that are specifically designed to identify existing assets and build social, political, and economic power among a critical mass of community residents in historically underserviced and under-resourced communities. Dr. Iton received his medical degree at Johns Hopkins Medical School and subsequently trained in internal medicine and preventive medicine at New York Hospital, Yale, and Berkeley, and received board certification in both specialties. Dr. Iton also received a law degree and a master's of public health from the University of California, Berkeley, and is a member of the California Bar. He serves on the board of directors of Consumer Reports, Jobs for the Future, the Center for Disease Control Directors Advisory Committee, and Grantmakers in Health. Believe it or not, this is an abbreviated version of Dr. Iton's extremely impressive and comprehensive bio, which indicates the vast impact of his work and commitment to advocating and pushing to eliminate health inequities. If you all could join me in welcoming Dr. Iton, he will begin his presentation now.
Good evening, everybody. It's a pleasure to be wherever I am, wherever you are. It is definitely surreal to do this presentation on Zoom, but I tend to prefer being face-to-face with people and seeing your reactions and trying to read your emotions and being interactive. But, you know, we are in a different time. So, you know, we have to accommodate. So I'm going to try to share my screen now and take us through some slides that are really, it's three phases of this conversation. One is sort of the underlying data about sort of what is it that we see when we start to analyze sort of patterns of health across places. And then two, I'm going to talk a little bit about how the environment actually gets under the skin and changes people's physiology in ways that actually make us more prone to disease, particularly chronic disease. And then three, I'm going to talk a little bit about an approach to intervening in that reality. And then I'm going to ask you to talk to me about what you think of all of that. And hopefully we'll have an opportunity to dialogue a little bit. Okay, so here goes the screen share. Let's see if this will work. I think it's this one. No, it's not that one. Let's try that again. Or maybe I can just make it that one. Okay. And let's go here. And I'm hoping you're seeing my slides. If somebody could just say yes, that would be helpful.
We're actually seeing the presenter view of your slides, sir.
Okay. Well, let's fix that then. Thank you. Let's exit that. Close this. Sorry about that. This is always a little bit challenging for me because I've got two screens, so I'm not sure who's seeing what. All right, so let's try this again. And let's bring that up. Give it a second. Sorry about this. It worked a few minutes ago. Okay. What are you seeing now?
We are seeing your file manager with the same thing, the presenter view again.
Oh, that's not good. Okay. Let me see if I put that down, open that up, and open this up. What are you seeing now?
We are seeing just the PowerPoint inside of MS PowerPoint.
Okay. I'm going to unshare and then share again because I think that that may be the problem. Sorry about that. Let's see how we do this now. Okay, let's go to this. And now we'll open it up. Sorry about that. Hopefully this will open up the right way this time. Okay. What are you seeing now?
Perfect.
Now you're seeing it? Okay, good. All right. Well, that's all the time we have, folks. Okay, so let me get into this and start with a quote that I really like. This comes from Rudolf Virchow, who's a noted pathologist, but he's also one of the first recorded social epidemiologists in public health. And he has a number of quotes. One of them is, physicians are the natural attorneys of the poor, and social problems fall to a large extent within their jurisdiction. And Virchow was a guy who was in service to the Prussian government in the mid-1800s and started to recognize how social structure and political structure impacted health outcomes. And he started writing about this very early on. And in some ways, what Virchow was saying in the mid-1800s is almost identical to what I'm saying to you today. So what I'm saying to you is not new, and I'm certainly not the first one to say it. The challenge is to get people to listen to it and then to act on it. Okay, so one of the things that I always do, because I'm a doctor, but I'm also a lawyer, is that I state my conclusions up front. And in stating the conclusions, I want to actually kind of set up an understanding for you about what I think is the dominant paradigm and what I think is actually the accurate paradigm. One of the dominant paradigms in public health and health in general is that health is behavioral, and that in fact, health is the product of smoking, drinking, driving without a seatbelt, or whatnot. And at the individual level, our goal is to change people's behavior. Another paradigm is that health is transactional, meaning that it's really about the quality of medical services, access to technology, the best pharmaceuticals that determines health and health outcomes. And a third paradigm is that health is genetic, and that in essence, your genes determine your life trajectory, and it's kind of like a lottery. Those with good genes do well. Those with bad genes are unfortunate, and there's some things we can do to try to tinker with people's genes, but in general, they don't work very well. And so what I want to tell you about these three paradigms, behavioral paradigm, the transactional paradigm, and the genetic paradigm, is that I think that they're all only slightly right. I mean, they're so minimally right that they're basically wrong. And in fact, the paradigm that explains health and its distribution across our society much better than any of these three paradigms is that health is political. And by political, I mean small p political. I don't mean Republican, Democrat. I mean one definition of politics, which is the struggle over the allocation of scarce or limited precious social goods. This idea that politics is about essentially interest groups coming together to contend for an allocation of goods. And these goods, in the case of public health, might be things like a grocery store in your neighborhood or a park. These are health protective amenities that are not equitably distributed across our society. We see neighborhoods that are routinely devoid of many of these precious and health protective social goods. And so this is the paradigm that I want to dive into in this talk. If health is political, it means that power matters. And that means small p political power. We think it's political power, social power, and economic power at the community level all matter. And they correlate much better with the health status of a community than does the behavior or access to healthcare or the genes. So I'm going to show you some data, and I'm going to try to explain that data to you, the patterns in that data based on this political paradigm, because the other paradigms don't explain it. But first, I want to give you a couple of other conclusions. Health is not health care. Health is an investment, whereas health care is an expenditure. And if you actually invest more in health, you spend less on health care. Where you live matters, and it matters a lot. And I'm going to try to show that to you in the next few slides. And then finally, health, as I said, is an investment. And the countries that have figured this out, the United States is not one of them. The countries that have figured this out have invested in their social contracts or social compact, I'll explain to you what that means later on, have better health. So countries that do more upfront investment in their populations have better health on the downside, or at least on the downstream side, than the United States. Okay, so let's get into this a little bit. I'm going to read this to you mainly because I find it actually kind of fun to provoke you a little bit, and I can't see your faces, so it's less fun for me. But let me go ahead and read it. I will say then that I am not, nor have been, in favor of bringing about in any way the social and political equality of the white and black races. That I am not, nor ever have been, in favor of making voters or jurors of Negroes, nor of qualifying them to hold office, nor to intermarry with white people. And I will say in addition to this that there is a physical difference between the white and black races, which I believe will forever forbid the two races living together on terms of social and political equality. And inasmuch as they cannot so live, while they do remain together, there must be the position of superior and inferior. And I, as much as any other man, am in favor of having the superior position assigned to the white race. Now, typically, if we were in person, I would ask you who said that, but we are not. I'm just going to tell you that that was Abraham Lincoln, the great emancipator, the man who freed the slaves. And many of us have been to the Lincoln Memorial. Many of us have seen words carved into what I presume is marble at the Lincoln Memorial. You see the second inaugural address, you see the Gettysburg Address, but you don't see Lincoln's overt white supremacy carved into the walls of the Lincoln Memorial. If we had time, I would ask you why that is, but we don't, so I'm just going to move on, and then you'll see why I think that is. I want to go on to say what Lincoln went on to say, which was in that same speech that I quoted earlier: our Republican system was meant for a homogeneous people. As long as blacks continue to live with the whites, they constitute a threat to the national life. Family life may also collapse, and the increase of mixed breed bastards may someday challenge the supremacy of the white man. So it's hard to read this and not conclude that Abraham Lincoln was a white supremacist. Okay, so I could spend a lot more time talking about this, and I won't because we don't have a lot of time. But what I want to suggest to you is that there is a competition, an ongoing battle between narratives in this country. And those narratives are powerful. And those narratives shape policy, and policy creates conditions. And I'm going to explain that to you as we go through this slideshow. But this image is meant to illustrate two dominant narratives in this country. One is a narrative of exclusion, which is what Abraham Lincoln, in his white supremacist speech, was essentially promulgating this idea that there are superior and inferior people, and there are certain benefits that the inferior people should not have and should never have access to. And then there's another narrative in this country, which is really about inclusion and about how we all do better when we all do better, and that our fates are inextricably intertwined. Those two narratives have been in battle since before even the beginning of this country. And I want to illustrate to you how it shapes policy and how that policy creates conditions that dramatically impact health in a very predictable way, mind you. Okay, so there are background themes in our country. There's income inequality. There's mass incarceration. There are student-led protests on campuses. There's a refugee crisis going on in many parts of the world. There's Black Lives Matter and the George Floyd public police-sanctioned murder. And there is the Moral Mondays in North Carolina, if any of you are in North Carolina, which is essentially led by this Reverend William Barber, who's breathing life into Martin Luther King's Poor People's Campaign, which was the last campaign he was involved with before he died. There are Indigenous people's rights and Standing Rock. And the themes that run through all of these campaigns is exclusion. A population that has been pushed to the margins, whose voice doesn't matter, who are presumed to be less valuable, and therefore are organizing to demand their rights and their full entitlements as Americans. So a narrative of exclusion is a very specific thing. And there's almost nobody better than our current president in essentially promulgating that narrative. It does three things. The first thing a narrative of exclusion does is it intentionally dehumanizes the target of that exclusion, just like Lincoln was saying. In this case, the current president talked about Mexicans as bringing drugs, bringing crime, they're rapists. Other politicians have talked about makers versus takers, or the 47% who are essentially dependent on government spending. Welfare queens, crack babies, you've heard them all. But the goal here is to say that these people are slightly less human, that they're not quite us, and they're not fully deserving of all the benefits of being an American. The second thing that a narrative of exclusion does is it exaggerates the notion of scarcity. And it suggests that there's this zero-sum competition, winner take all, for all resources. That may be jobs, it may be housing, it may be healthcare. And this idea that if that group gets it, that means they have to take something from us. And the third thing that a narrative of exclusion does is it looks to the past nostalgically and says, we were great back then, we need to be great again. It ignores things like slavery and Jim Crow and the Chinese Exclusion Act and the internment of the Japanese and the wholesale slaughter of Native Americans. It looks to the past and just absolutely whitewashes all of the crimes that occurred against people of color and low-income people and women and LGBTQ populations. Okay, so then competing with this is a narrative of inclusion. And as I said, that there are these two competing narratives. And the reason I'm setting this up for you is that it shapes everything else that I'm going to say. The narrative of inclusion does almost the exact opposite of the narrative of exclusion. It changes the narrator. It allows people to tell their own stories, to speak for themselves. It allows them to demonstrate their shared humanity. It also broadens the lens to show that we're mutually dependent, and COVID-19 has proven that beyond anything we've ever seen. Our fates are interconnected. It also highlights that we live in a country of abundance, the wealthiest country on the face of the planet, and that we're in fact not in a scarcity situation. And then finally, it looks to the past realistically and acknowledges many of the wrongs that have been done throughout this country's history, and it looks to the future with purpose and hope. Okay, let me pivot quickly to COVID. I want to quote W.E.B. Du Bois. And I think it's important in understanding health equity that you actually understand a little bit of American history. You have to understand how we got to where we are. We didn't just show up here. This is in 1899, so over 100 years ago. Du Bois said the most difficult social problem in the matter of Negro health. He's talking about health disparities. The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation towards the well-being of the race. There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. So what he's essentially saying is that we know that African Americans are suffering in this country, and their health is suffering, and we don't care. America doesn't care. Okay, so now we fast forward to COVID-19, and we find wholesale disproportionality amongst African Americans, Latinos, Native Americans, Pacific Islanders, populations that have been made socially vulnerable by our policies. And Reverend Barber, the person who I showed you the picture of, who's taking up the Poor People's Campaign and now has Moral Mondays, coined this concept of policy violence. Policy violence is the absence of affirmative policy in the face of abject need. It's knowing that people need health insurance because over 100 studies have shown that if you lack health insurance, you're more likely to die earlier and to suffer throughout your life with a whole host of preventable and treatable diseases. That's an example of policy violence, knowing that people lack health insurance, but not creating policy to ensure universal health insurance. And of course, we're the only industrialized country in the world that doesn't have a program of universal health insurance. So policy violence is what explains COVID's disproportionality. It's not that African Americans or Latinos are genetically more susceptible to the coronavirus. It's not that they lack access to healthcare. They do, but that doesn't explain, doesn't fully explain these dramatic differences. And it's certainly not genes and or behaviors. So what does explain it? What explains it is essentially a legacy of policies that have essentially provided for some and denied opportunity to others, and therefore put some populations in harm's way. And we'll talk about that a little bit more. What we do in this country, though, because of the narrative of exclusion, is that we blame the victims. We blame Black people for being obese, or having, high blood pressure, or, having diabetes. And, we have politicians whose first instinct is to blame the people who are dying more frequently. Some politicians are talking about, oh, maybe Blacks don't like wearing masks. Maybe they're not social distancing. Well, we know that there are layers of inequity that have compounded COVID-19. We know that African Americans, Latinos, because of their greater likelihood to be essential, so-called essential workers, are at greater risk of being exposed to the virus. There are also, at least early on in the epidemic, and in California we've eliminated some of the testing disparities, but early on in the epidemic, if you were Black or Latino, trying to get tested was a much harder thing to do than if you were white. We know that there are health disparities as a result of historical deficiencies in access to opportunity. And then finally, we know that there's access to healthcare. So you layer that all together and you get COVID-19's disparities. I'm going to come back to COVID-19 towards the end of the talk. But first, I want to talk about place. This is where I grew up. I grew up in a very nice city. It's an island in the middle of a beautiful river. It is not in this country. It has very good parks, housing, wonderful restaurants, state-of-the-art public transportation. This is Montreal, Canada. This is downtown Montreal with the St. Lawrence River in the background and McGill University in the foreground, looking down from Mount Royal, from whence Montreal gets its name. And I grew up there in the 60s, 70s, and 80s with two brothers, three black boys growing up in Montreal, Canada. And Canada has a strong social contract. It has universal health insurance for all Canadians, got universal dental care for all children, a universal child care benefit, paid sick leave and vacation for all employed people, state-of-the-art public transportation that's highly subsidized across all of the major cities, very subsidized post-secondary education. I went to McGill University, which is sometimes referred to as the Harvard of the North, for free. In fact, I got paid to go there. My scholarships were more than my costs. And it's got high-quality resources, parks, libraries, community centers. I want you to focus on just one aspect on this slide, and it's one word, and the word is universal. If you want to understand the strength of a country's social contract, look for that word. Okay, in the mid-1980s, I left Montreal to go to Baltimore, Maryland, to go to medical school, and ended up at Johns Hopkins Medical School because somebody told me it was the best medical school in the world. I don't know whether that's true, but at Hopkins, they do have a saying, which is, we may not be the best, but there's nobody better. So Hopkins definitely thinks it's true. And when you get down to East Baltimore, where Johns Hopkins is located, this is what you see. These are images from East Baltimore immediately adjacent to the medical school. And I was being toured around by an upperclassman early on in my time there, and I couldn't understand what I was looking at. I had never seen scenes like this in Montreal, Canada. And I asked the upperclassman, when was there a war here? It looked to me like the place had been firebombed. And at the time, Beirut was in the news because of the constant wars that were going on in Beirut. And this looked like Beirut to me. There was rubble on the street. There were burnt out buildings. There were cars that were burnt out up on jacks. There was garbage piled up to people's waists. And there were dogs wandering in and around this, just wild, loose, mangy dogs. And babies playing in and amongst all of this. And I couldn't understand what I was seeing. And I'll never forget what the upperclassman said to me. He looked at me like I was the stupidest idiot he'd ever seen. And he said, what did you expect? This is the inner city. And I thought, oh, so I'm the idiot. I should have expected these conditions. This is an American norm. This is something that America is very comfortable with. These are essentially environmental conditions that are replicated all throughout the United States and expected. And the fact that most of the people in this community looked like me was what was most shocking to me. It was that this is how I was thought of in this country. And I thought, well, what if I hadn't grown up in Montreal? For all intents and purposes, this kid is me. This kid didn't create this environment any more than I created the environment that I grew up in Montreal. Yet this kid has to navigate this bombed out environment every single day of his life. And these kids are not stupid. They internalize this. They see that they're being devalued by this society. And that devaluation, initially, it causes an anger in young people, this sort of roiling outrage that these are their conditions. And then that outrage turns into just a seething rage, an overt rage at that system. And then over time, it just weathers people. It wears them down, and they lose hope, and they lose a sense of the future. And I saw that over and over and over again in East Baltimore. And it's an entirely normal human reaction to oppression. Okay, it's not just East Baltimore. This is southern Indiana, a place called Scott County. It's notorious in public health circles because it had in 2015 the highest HIV incidence in the world, higher than sub-Saharan Africa. And Scott County was driven by an IV drug epidemic, and people were grinding up this drug called Opana, and injecting it, and it was a thick kind of slurry that they were injecting, and it required relatively large needles, which are highly efficient at transmitting infectious disease, and they were sharing those needles, and people were getting HIV and hepatitis C. And the only difference that I can discern between Scott County, Indiana, and East Baltimore, Maryland, is that Scott County is 98% white. And to my mind, what this illustrates is essentially two sides of the same coin. You see the white and black faces of income inequality in the United States. This is how a lack of a social contract manifests itself in this country. And because of our history of segregation, racially segregated communities, you see this manifesting itself in urban inner cities and African Americans and Latinos, and rural communities in white populations. I'm going to touch on this again in a minute. And so the question for us is, like, what's the American social contract or social compact? I mean, what is it? And again, if we were in person, I would actually ask you this question. Remember, I said universal policies. What are the universal policies in the United States that are investments that are designed to head off inevitable strains and stresses later on in life? Universal health care is not just about the health care, it's about the universality. It's about that sense of reassurance that if anything happens, you've got a society that's got your back. So think about that for a minute, and maybe we can talk about it in the questions and answers. What is the American social contract? Okay, so I left Baltimore with this question in my head, which was essentially this. In the United States of America, when it comes to your health, does your zip code matter more than your genetic code? And this is the data piece where I basically set out to try to prove this. So this is a map of the San Francisco Bay Area, for those of you who don't know it. This is San Francisco. It's a relatively small place, and I became the health director, health officer of Alameda County, which is this large boot-shaped county that looks like it's trying to crush San Francisco. And we tried, but, to no avail. And so I'm showing you the shape of this county, Alameda County, because I want you to understand the maps that I'm going to show you in a minute. But in the sort of the toe part of the county, you've got older cities like Berkeley and Oakland. And then going down the heel, you've got a sort of a 1970s era freeway that takes you to 1970s era suburbs like Fremont and Union City. And then along the laces of the boot, you have a 1980s era freeway that takes you out to 1980s era suburbs like Pleasanton and Livermore and Dublin. And on the back of the boot, it's largely rural. And also there are nuclear bomb makers that have actually big installations out there, including Lawrence Livermore National Labs and Sandia National Labs. So that's kind of the lay of Alameda County. When you're the health officer, you become essentially the registrar. You're the registrar of all births and deaths. There are about 20,000 births in Alameda County every year, about 10,000 deaths, and every one of those deaths has a death certificate associated with it. And on a death certificate, you can tell what somebody died of, what their age was when they died, their race, ethnicity, and where they lived. And you can take, we took almost 500,000 death certificates, put them into a database, and analyzed these four elements and a few other elements to actually look at patterns of death across Alameda County. So the first thing you can do with that database is you can take, again, the boot. This is Alameda County. And you can look at each of the individual census tracts, which are rough correlates of neighborhoods. Each census tract, about 150 of them in Alameda County, has about 10,000 people in it. And you can calculate on average, based on death certificates, how long on average somebody can expect to live in that neighborhood. And so you see in the sort of the foot part of the boot, you see the cities of Oakland and the cities of Berkeley. And those red areas are areas where people can only expect to live to about 74 years. In the green areas, in the Oakland Hills and the Berkeley Hills and other parts of the County, people can expect to live greater than 80 years. And between the red and the green are the yellow areas where people can expect to live between 74 and 80 years. And the first thing you notice about this map, the first thing you notice is that it is not like a Christmas tree. It's not like these colors are randomly distributed. They cluster, and they cluster in parts of Oakland in the flatlands, and Berkeley in the flatlands, and some of the unincorporated areas along that freeway that I told you about that runs to the heel of Alameda County. And these are places where we provided a lot of public health services. This map got a lot of attention. It ended up on the front page of the San Francisco Chronicle, stimulated a lot of talk. It helped contribute to a documentary called Unnatural Causes. And, one of the questions people would ask is, well, what's wrong with Alameda County? Why do you have such obvious inequity manifesting itself in terms of the length of people's lives in a city? So you look at the red, and you see some red places that are immediately adjacent to green places. So you can have neighborhoods that sit immediately adjacent to each other with a life expectancy difference of 22 years between those two neighborhoods. And you see that in the city of Oakland and in the city of Berkeley. And people just didn't understand how that could be. Well, the reason I made this map was because I'd been in East Baltimore, and I knew that this was not unique to Alameda County or Oakland. So we took our map of Alameda County, and we went back to Baltimore, and we did the same map there. And we found in Baltimore neighborhoods with life expectancy of 58 years, as well as other neighborhoods with life expectancies approaching 90 years. We didn't stop in Baltimore. We went to Cleveland, Ohio, to look at Cuyahoga County, found similar disparities there, almost 30 years of life expectancy difference across Cleveland. We went to Denver, we went to New York City, we went to Seattle, King County, at Los Angeles, Minneapolis, St. Paul, Boston, Philadelphia, San Antonio, Chicago. We actually went further, went to Cincinnati, everywhere we have looked, we find life expectancy differences between neighborhoods in the same city on the order of 12, 15, 20, 25, and in one case, 30 years. This is the American pattern. What I saw in East Baltimore was not unique to Maryland or Baltimore. What I saw in Oakland is not unique to Alameda County or California. The American pattern is to distribute life expectancy by neighborhood. This is how we pattern opportunity in this country. And so when you look at these maps, you have to ask yourself, well, can you explain this by those other paradigms that I described to you at the beginning of the talk? Is this behavioral? Do people cluster in neighborhoods and just adopt risky behaviors based on being in the same neighborhood? So smokers all live in one part of town, and the drinkers live there too, and drug users live there too, and that explains these patterns. Some people have tried to explain this that way. It doesn't work. Can you explain this by access to healthcare? No. In fact, to the extent that there's a correlation, there's much more healthcare utilization in those neighborhoods that have relatively low life expectancy. So if anything, there's an inverse pattern, and you'd have to conclude that healthcare was bad for your health if you believe that that was the explanatory variable that made the difference, and it is not. Can you explain this by genes? No, you cannot. And I can go into any number of different ways that you can disprove any of those different paradigms. The only strong correlate of these differences is power, is political power. Again, small p political power. And we can talk about that. The other thing you can do with these maps, by the way, this is Alameda County again, the top left is life expectancy, the bottom right there is the poverty map from the census. So you can figure out the percentage of people living below the federal poverty level on each of those census tracts. And then you can correlate these two things, and you end up with this graphic, which is essentially on the up axis, you've got life expectancy, so from lower to higher. And as you move from left to right on this graphic, you're moving from relatively wealthy communities to relatively poor communities. So you see a higher percentage of people living below the poverty rate. And you see that each of those blue dots is a census tract. So you see that as you move from left to right, that life gets correspondingly shorter. In an ideal world, this would be a flat line. Where you live wouldn't predict how long you live, but we don't live in an ideal world. We live in a world where you can predict reliably how long somebody will live based on their address. So that was Alameda County. We did the same analysis for the entire San Francisco Bay Area, and then for the entire state of California, and you see that the slope of this line has meaning in it. We've since replicated that for a number of other states as well. One of the things that we try to do with this work is get it out there, disseminate it, let people know. And you can't put a graphic like that on the front page of the San Francisco Chronicle, but you can put this, which is essentially the monetizing the slope of that line I showed you, which basically correlates to $12,500 in every additional $12,500 in household income buys you a year of life expectancy. So that's essentially the cost of life in the San Francisco Bay Area. And different places have different slopes and therefore different life values in their regions. I'm not going to spend a lot of time on this graphic because I don't know how well you can even see it. But this is some work that was done looking at essentially the same basic concept, the slope of the line between poor and rich, between American cities, which are in that blue line, and then Canadian and Australian cities, which are, if you can see it on the lower right, the red is Canadian cities and the green are Australian cities. And what you see, in essence, is that the American line is much steeper. The Canadian and Australian lines are almost flat, meaning that you don't see dramatic differences between neighborhoods in health outcomes in other countries than you do in the United States. And again, we can spend more time on this. There are a lot of researchers who spend a lot of time analyzing this. The United States is almost unique in the world in developed countries in having these dramatic gradients, these so-called social gradients between essentially rich neighborhoods and poor neighborhoods. So we spend a lot of time in this work, again, popularizing this, disseminating it, shouting it from a mountaintop. These are real zip codes with real life expectancies in California. And one of the questions I would frequently get when doing these presentations is, people would come up to me and say, hey, Tony, you seem like a really nice guy, but you got this all wrong. The reality is that the U.S. is the healthiest country in the world. And the problem is that you're looking at everybody all together. And in fact, if you just looked at white people, you would see that whites are by far the healthiest population in the world. And I would always say, okay, that's very interesting. Do you have any facts to back that up? And they're like, it's just known. It's true. We're number one. So, I decided after hearing that enough times that I would actually have to make some slides. And so one of the things I like to do is to sort of just look at sort of like the general media and see how people are talking about health. And here's Time Magazine with a cover article called A Sorry State of American Health. And you know that that's not going to be good news. Let me show you a little bit of data that you've probably already seen before. This is spending on medical care across developed countries. And on the far left of this graphic, you see the United States, which is essentially spends on a per person basis twice what the rest of the developed world spends. And so whenever you make this graphic, you actually have to change the axis to fit the United States on with the rest of the world. You've probably already seen that. You may not have seen this. Hopefully some of you have. This is an analysis that was done by two brilliant female health services researchers. And I highlight the term female because I think it makes a difference. And I think that the thinking that led to this analysis really comes from people who have a more holistic understanding of what health is. And women tend to have a more holistic understanding of health than do men. I'm sorry, men, it's true. Women are smarter than we are when it comes to understanding these phenomena. So I showed you this per capita spending on healthcare. This is per person spending on medical care. Well, this is that same data. Now, instead of being in red, it's in blue. And so you see the United States sort of towards the middle there, and you see our big blue line. But what these two female health services researchers did is they added to per capita spending on healthcare, per capita spending on social services and social benefits. And that's how they created this graphic. And when you do that, the United States is no longer the big spender. We're actually comfortably in the middle of the pack. The reason I show you this data, other than the fact that I really respect these two women, is the fact that if you look at those now brownish red lines, that is the respective country's investment in their social contract. So that's on a per person basis what those countries are investing in policies, largely like universal health care, universal child care, paid sick leave, vacation days for workers. That's being built into those red lines. And what they showed with this is that the countries that spend disproportionately more on social services and benefits compared to medical care actually have better health. And these are those two women, Elizabeth Bradley and Lauren Taylor. They wrote this up originally as an op-ed in the New York Times. It ended up getting so much attention that they made a book out of it called The American Healthcare Paradox. I showed you the crux of their book. It was essentially that graphic. And these are the two of them giving a TED Talk not too long ago. So what they showed is in the rest of the developed world, for every dollar spent on healthcare, roughly $2 is spent on social services. So a 2-to-1 ratio between social services and benefits and healthcare spending in the rest of the world. On the right side of this graph, you see the United States. For every dollar we spend on healthcare, we only spend about 55 cents on social services and benefits. And the kind of benefits we're talking about, you can see on the left side of the graphic on the bottom: unemployment, social assistance, housing, family, single parent benefits, et cetera, et cetera. And so they showed that the right ratio for actually getting the best health bang for this investment was about 2-to-1. If you want better health in your country, spend about twice as much on social services and benefits as you do on healthcare. And again, the United States spends about 55 cents for every dollar. This correlation has been studied by not just Bradley and Taylor, but by Rand. They got together and everybody was so shocked by what Bradley and Taylor came up with that they said they have to replicate it. It couldn't possibly be right. How could all of the male health service researchers have missed this for 40 years of doing these kinds of studies? So Rand replicated their study with more countries and including every single individual state in the United States. And they found that not only were Bradley and Taylor right, they were actually even more right than even they thought they were. And this graphic it looks complex. It's actually quite simple. If you look at the upper dark orange line, that's social spending in the European Union from 1980 to 2010, so that 30-year period. The dark blue line is social spending in the United States across that same period. So you see this persistent gap across that period of time. And then you see the sort of the shaded blue lines. Those are the shaded lines. The shaded orange is life expectancy. Again, in the United States, in the blue, and in the European Union in the light orange. And you see that in 1980, those two life expectancies are roughly the same. And you see that gap just growing over that 30-year period, so that U.S. life expectancy starts to lag behind EU life expectancy. And then the third thing you need to see is those dotted lines. The blue dotted line is U.S. medical care spending. So that's health spending in the U.S. from 1980 to 2010. You see the trajectory of that line. And then look at the orange dotted line. That's European Union health spending over that same period of time. So the correlation there, and you don't have to be a rocket scientist to see this, is that essentially spending more on social spending correlates with better life expectancy over time. Okay, let me just pound this home to you because I think that this is kind of one of the biggest takeaways of this presentation. This is what the Rand Corporation concluded. Higher levels of social spending are strongly associated with better health. Let me repeat that. Higher levels of social spending are strongly associated with better health. So I could just stop there and say, I said all I need to say to you, but I won't. Rand goes on to say the association is particularly strong for public spending as opposed to private social spending, meaning government spending as opposed to private spending is the way to go. They also conclude that the association between social spending and health outcomes is strongest where income inequality is greatest, like the United States. In other words, social protection may be more important for health outcomes in more unequal societies. And then finally, these associations hold across individual states within the United States. So when you compare Connecticut to Mississippi, you see the same phenomenon. Okay, I told you that people would tell me that if I just looked at whites, I would see how healthy America was, so I did. U.S. white life expectancy is about 79 years. That's actually a little generous. It's dropped 3 out of the last 4 years. It's about the same as Qatar, Costa Rica, and Nauru. But U.S. whites are living shorter lives than Belgium, Chile, Denmark, Lebanon, Slovenia, Austria, Finland, Germany, Greece, Ireland, Malta, Netherlands, Portugal, the UK, Canada, Cyprus, France, Iceland, Israel, South Korea, Luxembourg, Monaco, New Zealand, Norway, Sweden, Andorra, Australia, Italy, San Marino, Singapore, Spain, Switzerland, and Japan. There's 33 countries in the world that have longer life expectancy than U.S. whites. In 1990, there were only 17. U.S. white life expectancy is actually in free fall. It's unanchored from, the higher life expectancies in the world. It's just falling. Falling so quickly, in fact, that many health disparities researchers no longer use white American life expectancy as a benchmark to compare other groups against. We're much better off comparing to immigrant Latinos or immigrant Asians or immigrant anybody. Immigrants all have better health status than their American-born, constituents. And as they acculturate, their health actually gets worse. But don't believe me. You can believe the National Academies of Medicine, or what used to be called the Institute of Medicine, published this report in 2013 called Shorter Lives, Poorer Health, which compared the U.S. health status to 17 peer countries. And this was their conclusion. The panel was struck by the gravity of its findings. For many years, Americans have been dying at younger ages than people in almost all other high-income countries. This disadvantage has been getting worse for 3 decades, especially among women. And the U.S. health disadvantage cannot be fully explained by the health disparities that exist among people who are uninsured or poor. As important as these issues are, several studies are now suggesting that even advantaged Americans, those who are white, insured, college-educated, or upper income, are in worse health than similar individuals in other countries. This phenomenon is getting a lot of media play. This is the PBS NewsHour talking about why so many white Americans are dying young. It's a Wall Street Journal looking at declines in life expectancy for white women. This is another, I forget which newspaper this was, but it talks about this phenomenon of deaths of despair, which are overdoses, alcohol-related organ disease, and suicides that are disproportionately killing white Americans, particularly in rural places like South Indiana, like I showed you earlier on in the presentation. This concept of deaths of despair actually comes from 2 economists at Princeton, Angus Deaton and Ann Case, husband and wife. Angus Deaton won the Nobel Prize in 2015 for his work in economics, but they published a study looking at life expectancy. Actually, these are mortality rates from 1990 to 2010. And when you look at this graphic, you get a basic sense of what they're trying to show you. Every single one of those lines is essentially in parallel heading down. These are mortality rates, so they're the opposite of life expectancy. You want low mortality rates. And you see this trend of decreasing mortality rates in every single country. That sort of bright blue line is U.S. Latinos, and you see that as well. African Americans are not on this graphic because you'd have to actually extend the axis to fit African Americans on, but you do see a parallel decline in mortality rates in African Americans. What you don't see a parallel decline in is U.S. whites, which is that dark red line that's sort of going across the top there. You see not only a flattening of mortality rates, but you see an increased mortality rates, which is unprecedented really in the history of the United States and modern epidemiology. So that phenomenon has been ascribed to deaths of despair. And, this has been picked up again in the news. U.S. life expectancy dropped 3 out of the last 4 years. much of that drop has been ascribed to deaths of despair. Even Sanjay Gupta has been talking about this in a documentary, which he gets, I'd say about 70% of it right. So let me keep moving on here. Again, real zip codes, real life expectancies. We try to make this phenomenon understood. This is in Sacramento, which is our capital. When Sacramento built out its airport, we decided we would literally decorate the walls with these images, and then legislators started calling me, asking me why I was decreasing property values in their districts. This was downtown San Francisco during APHA a few years ago, where we festooned the Metreon building downtown right next to the complex where APHA was being held. This is San Diego at APHA last year, and similarly, we decorated the essentially downtown with these images because we think it's really important that people understand what health really is and what it isn't. Okay, so we know that 80+% of what influences your life expectancy happens outside the doctor's office. Why? Well, this is fundamentally through this phenomenon called allostatic load or chronic stress. And that is that, in essence, there are all of these stressors in our lives, and we try to balance those stressors with resources. And if you have stressors and relatively few resources, you're out of balance, and that changes your physiology. And the way the body processes this is the brain perceives the stressor through the hypothalamus. It sends a message to the pituitary gland, which sends a message to the adrenal glands, which release a cascade of hormones, including cortisol. In the acute phase, when you're walking across the street and a truck starts barreling down the street towards you, you're in the blue. You have a surge of cortisol, your cardiac output increases, glucose is rallied from your muscles and your liver to essentially allow you to sort of flee. Your immune functions are enhanced, your inflammation is turned down, and you actually have the growth of neurons in your hippocampus and your prefrontal cortex, which are responsible for what's called executive function. Executive function is essentially the ability to make quick decisions when you have very different options. So we all have the blue stress response. It's all helpful. If you're living in a place like East Baltimore or Southern Indiana, and you're constantly dealing with this imbalance of resources, you're experiencing, forgive my neighbors are lawn mowers are going here. You're constantly having cortisol circulate through your body, and that's not good for you. It stimulates hypertension and cardiovascular disease independent of your diet and your physical exercise. It causes glucose intolerance and insulin resistance. It turns up inflammation, turns down your immune system, makes you more prone to infection, and it causes atrophy and cell death in that same part of the brain that I told you was responsible for executive function. So people who live in low-income communities that are routinely seeking access to resources that they need for health are frequently living in the red. They're basically living in a fog of chronic stress. And over time, that changes their physiology. It weathers them. It wears down their bodies. It drives premature aging and death. And the sad thing is it actually changes the expression of people's genes, and it can be passed on to your children. All right, let me start to wrap up here. I want to talk about a way of understanding all of this. This is a framework that came together by a group of public health officials in the San Francisco Bay Area. And this first part of the framework just looks at the medical model. The medical model, and you read this kind of like Hebrew or Chinese from right to left. So we start on the far right looking at mortality or death. And when you see high rates of premature death, like I showed you in those neighborhoods that were red in Alameda County, you have to start thinking, well, what's driving that rate of death? Generally, it's a high burden of disease and injury. And when you see a high burden of disease and injury, you have to ask yourself, well, what's driving that? And that takes you to the next box, which is about risk, both risk factors and risk behaviors. And so risk begets disease, disease begets death. That's basically the medical model. And the interventions are to try to change people's behaviors. We use health education, typically brochures and pamphlets, to try to change their course of disease. We use clinical medicine, typically 15-minute interventions in a cubicle, and sometimes we try to tinker with people's genes. This is a $3.8 trillion enterprise at this point, and I'm not arguing with you that it's not necessary. It's absolutely necessary. It's just not sufficient. And so these public health practitioners added to this framework and said, we can't just look at the medical model. We have to look socio-ecologically about how we're structuring society in ways that is actually steering people towards risk. And can we restructure society in a way that actually reduces the upstream risk so that there's less burden on downstream medical systems? That's what this framework is about. It's not a model. It's not trying to explain the universe. It's just sort of expanding the opportunities for intervention. And so we intervene like crazy downstream. As I showed you, the US spends more per capita on medical care than any country in the world. We spend very little upstream where other countries invest in their social contract. And so the opportunities for investing in the social contract are upstream on the green part of this framework. Again, reading from left to right, if you start with that middle box that says social inequities, that's the East Baltimores or the East Oaklands or the South Side of Chicago or the Scott County, Indianas. Those are concentrated areas of essentially resource-depleted communities where people are struggling to find access to health protective resources and therefore are constantly bathed in chronic stress. And the question for us is, well, what produces those kinds of conditions? And the answer is policy, which is the next box, which essentially emanates from institutions, from government, from corporations, from other institutions that essentially steer resources towards people who are favored and steer resources away from people who are disfavored. And then we have to ask ourselves, well, why is that? Why do these institutions behave in that way? And the answer takes you right back to Abraham Lincoln and that first set of slides that I showed you about narrative. It's about a story about who we think we are, a story we tell ourselves about who's valuable. It's the narrative of America. And that narrative is constantly evolving. There's competing strands of that narrative that try to dictate how policy should flow to essentially bring to life that narrative of who we are. And so the primary narrative that produces institutional misbehavior that creates conditions like East Baltimore is racism. That's in that first box, the isms. The history of this country is just enshrined in racism that creates institutional racism. It's manifest through policies that creates conditions that put people at extreme risk. So you think about COVID-19, you think about the conditions of being an essential worker, living in crowded housing, being dependent on public transportation, excuse me. Those are all risk factors for being exposed to the coronavirus. Those risk factors are not equally distributed across society. Certain populations who have been disfavored are forced to contend with those risks because of a narrative that creates policies and conditions that work in their disfavor. Okay, so let me move quickly to the end here. The health disparities, when you see them, are manifestations of downstream differences, people's inability to essentially access basic health care, and essentially are a manifestation of upstream health inequities. And you can take the word health out of there and just talk about inequities producing disparities, or you can be simple-minded like I am and talk about conditions, upstream conditions that produce downstream consequences. And that is essentially the paradigm that we think we have to intervene in. And it's not just health conditions downstream. You can see educational outcomes shaped by these same upstream conditions. You can see employment outcomes. You can see a whole host of outcomes that are shaped by these upstream conditions. So our argument has been, let's focus a little bit less on downstream, which is not to say that downstream doesn't matter. It does. But what is it we can do upstream to take the burden off of the downstream? And we've simplified what we do upstream into essentially three buckets. this notion of place. How do you improve the places, the conditions, the physical, social, economic environments in which people move in and about every day, particularly low-income communities of color? How do we enhance those environmental conditions so people essentially find access to resources instead of the routine impediments that they face on a day in, day out basis? But that's insufficient. We have to deal with the policy that creates those conditions, and then we have to deal with the narrative that creates that policy. And one key aspect of this is building power. At the end of the day, as I said in those early slides, health is political. And if it's political, it means that power matters. And that's just not just voting power, it's social power, it's economic power. It's critical to essentially build power in a critical mass of people living in communities that are essentially on life support, and allowing them to hold accountable those institutions that shape the conditions that they have to navigate every single day. Okay, so healthcare costs live downstream, actual health lives upstream. The goal to right ourselves is to actually bring some of those costs upstream to create a virtuous cycle so that we can invest in more health and reduce the burden downstream. I want to conclude by talking about policy violence, because this is a concept that is at the root of all of this phenomenon. This idea that it's not necessarily affirmative policy that is racist or hostile. We had that in this country, and we have the legacy of that, but we also have to contend with essentially neglect. It's the absence of policy in the face of abject need. Again, the clearest example of that is the lack of health insurance, universal health insurance for people across this country. Okay, I think I'm going to show you this last slide, then I'm going to conclude. Very simply, the medical model says that bad behavior produces higher disease, which produces higher rates of death. And the socio-ecological model basically says bad societal behavior, the isms, produce policies and practices that create conditions of neglect in communities. And those conditions create risk, and that risk moves itself downstream. We have interventions to prevent death. We call them emergency rooms. Interventions to try to interrupt the course of disease. We call that clinical care. Interventions to try to change behavior. We call that health education. All of that's necessary, but not sufficient. We need interventions to enhance neglected communities. One approach is building power and leadership and a critical mass of people in those communities. We also need to intervene at the policy level and the practice level of institutions. We can do that by putting health in all policies and looking at the health consequences of non-health policies. And finally, we need to change the narrative. That's what health equity looks like, and that's what the practice of health equity looks like. I'm going to stop there and hope that we can engage in some questions. So let me stop sharing my screen. I really have no idea who's on the other side of this, so hopefully you all hung out with me.
Thank you, Dr. Iton. We do have quite a few questions that are rolling in, and I'm going to start from the top. There was one question regarding the unnatural causes. Do you know if it will be updated?
The answer is no. I wish the answer was yes, but the producers, one of them I hired, now works with me. But the producer, the primary producer, Larry Edelman, has retired, and I begged him to come back and update unnatural causes, and he says, nope, not doing it. And the other producer has moved on to other projects. So unless there's somebody in this audience that wants to become a documentary producer in public health, we will not be seeing an update of unnatural causes anytime soon. Larry Edelman did do another film in health, and it's called The Birthing of I think it's the Birthing of America, and it's about early childhood and our policies around that, but then he retired.
Great, thank you. There was another question that I think think you partially answered it. Did you map longevity and race in Montreal to compare it to the United States?
Yeah, I'm sorry. I think the question was, have we looked at looking at life expectancy by neighborhood in places like Montreal and Canadian cities and other cities? Was that the question?
Yes, and compare it to the United States.
Yeah. So I showed you that one graphic with those lines, one with the American slope and then the Canadian and Australian slope. So that is essentially that analysis. But we actually have engaged the Canadian Institute of Health Statistics to do a follow-up study of that, to map out 6 Canadian cities, and we're still working on that. But the data shows, what we already knew, which was you don't have profound social gradients in Canada like you have in the United States across cities. And so life expectancy differences across neighborhoods aren't as great. And we found similar data in Europe and Australia and in New Zealand, meaning that the U.S. is unique.
Okay, this next question has a couple of different parts. I'm going to try to rephrase as best I can. It says, as we are now recognizing the impacts of chronic stress, allostatic load, and the relations to epigenetic changes, do you believe our current practices of incremental policy changes are sufficient?
No, I love that question. That's great. I feel like I wrote that question. So, I didn't talk about epigenetics, and I could have. Again, I'm not entirely sure how much the audience has seen of some of this data, but so epigenetics is, I referenced it very briefly. When you have allostatic load, it actually changes genetic expression. That's what epigenetics is, and that those changes in genetic expression can be passed on to your children. And so given all of that, are incremental policy changes sufficient? And the answer is no. It's one of the reasons that we talk about narrative, because, if you think again about the framework that I showed you, those first 2 boxes, narrative begets policy, policy begets conditions. Too often in public health, we focus just on that policy box, and we think that we can sort of fix this one policy at a time. But the reality is that the reason we don't have a social contract in this country is because we lack social solidarity between groups, primarily between racial groups. And if you don't have social solidarity, people are unwilling to invest in universal policies. And to get to where we need to get to reduce allostatic load, we need to have more universal policies that invest earlier on in people's life courses that allow them to have higher life trajectories and essentially exercise their God-given talents and abilities. So fundamentally, we can't address that through policy. We have to address that through narrative, which is part of the reason that in California, we're working on creating a new California social contract, which is this idea of sort of enshrining that inclusive narrative into our California narrative so that all our policies flow from this idea of investing in all of us, looking at future generations, and recognizing that our fates are inextricably intertwined. And so that sounds airy-fairy or whatever, but I'll tell you, I can give you example after example in California of how we've actually changed the narrative. We've changed the narrative around undocumented Californians. We've changed the narrative around formerly incarcerated Californians. We've changed the narrative in the United States around LGBTQ families and marriage equality. We've changed the narrative in California about boys and men of color. All of that has led to policy changes that invest in these populations that yield much greater opportunity for people to have high and healthy life trajectories.
Great, thank you. The next question is regarding the framework slides. It says isms as upstream to institutional power, but this participant is wondering if you can comment on Dr. Ibrahim X. Kendi's thesis that power actually is upstream to the isms, and that isms are created and reinforced by those in power to justify the policies that maintain their power.
Yeah, I think we had Abraham Kindi come to our to give a presentation recently on anti-racism at our actually online, I guess, through one of these Zoom things. And you know, yes, the framework. You know, it's a much longer story. That framework that I showed you took about 10 years to develop. There's still disagreement. I mean, it's actually been renamed the Iton-Witt framework because it was originally called the Barhigh framework when I and some others were working at the Bay Area Regional Health and Equities Initiative and created the framework. And then after we left, some folks kind of revised it in a way that I didn't actually agree with. So I no longer really call it the Barhigh framework. I call it the Iton-Witt framework. Sandra Witt's one of the colleagues of mine who helped develop it, who's now with me at the California Endowment. And, you know, the big argument was, what's that first box? You know, what's the original sin? What's the root cause? And, you know, the isms don't just come out of nowhere. They are promulgated by people in power. Racism is a system of power, as are all the isms. They're not designed just as sort of like a thought exercise. They are designed to essentially allocate and distribute power and opportunity. And so embedded in the isms is that sort of system of power and a desire to sort of maintain that power to a certain group. So that's how, you know, I harmonize that box. The isms are about power in the end. And so you've got that aspect of power pushing into policy, and then you've got, you know, community power that you've got to harness to actually push into power, push into policy, and actually push into narrative, to change that narrative about who we are and what we hold as sacrosanct in our society. If somebody's talking, I can't hear you.
I can ask the next. Somebody, you know, Mike. So the next question is, if you could comment on the healthcare system attempt to address the upstream impacts. Are there any steps we can take in a given clinic visit to deal with this impact?
Okay, I didn't hear all of that, but I think I heard enough of it to make sense of it. You know, is there anything we can do in the clinical setting to impact this? And the answer is yes and no. You know, first, defining your impact to the clinical setting is pretty narrow. And, you know, there has to be a recognition that, you know, the clinical setting lives within other settings. So you live within an institution sometimes lives within a system. And so what's your role within that institution to have that institution influence policy? What's your role within that system, have that system exercise its system power to influence policy? So I'll give an example. Kaiser Permanente invested $200 million in affordable housing because it recognized it had an interest in its employees. It had an interest in the health of its community, and it realized that it had to make an investment to enhance policy to increase the amount of affordable housing, you know, in the places where it was operating clinically. So I want to say a couple things. One, physicians, nurses, people in the health field that are health practitioners have a lot of credibility in the policy space. For good or for bad, health practitioners are seen as largely unbiased and not motivated by money. So there's, I think, a concomitant responsibility to use that credibility to influence policy that you see impacting health. And so if you define your only influence to the clinical space, then you're I think, arbitrarily limiting the kind of influence that you can have over overall health. Now, in the clinical space, there are things you can do. I think that there's a clinical paradigm, which is that of expert and supplicant. The patient is sort of like, just this, passive entity waiting for you to disgorge knowledge into their, open beak. And that's a paradigm that is a flawed paradigm. It's actually a paternalistic paradigm, and it has racial connotations as well. Redesigning that clinical space, as has been done in any number of clinical settings around this country, including up in Alaska, South Central Foundation and their NUCA model, which actually flips the paradigm and has essentially patients, kind of engaging practitioners as, like you would engage a consultant on an architect on a house that you're building. But the clinic is actually under the control of the community, not of the healthcare practitioners. That's one particular model which kind of flips the script, recognizing that there's expertise amongst the patients that they can use to help each other, as opposed to this idea of sort of this expert paradigm, which is honestly, it's a white supremacist paradigm. It's this idea of sort of, white sort of knowledge, wisdom, savior that provides, very technical information to essentially passive patients who essentially are told to live like me, the doctor, not like you, the patient. And that is it's not a model that actually builds agency, which is a sense of control, or even a sense of belonging. And it's one of the reasons people kind of turn away from healthcare as essentially intimidating, paternalistic, and hostile to their basic identities. And we can design healthcare settings that don't essentially embrace that philosophy.
Thank you for that response. I think that's really rich. And we, as you may know, we have a number of dual degree clinical students who are also obtaining their MPH alongside of their clinical degrees. So I think that's really kind of something people kind of the clinical spaces where people will be employed, but how to actually, utilize both of those disciplines together. That's a really fascinating and important distinction that you just provided. So thank you for that. Another question is, what role can research play to disrupt policy violence? And I'd like to add to that question, in addition to policy violence, changing that narrative that you talked about.
Yeah, I'm working right now with Robert Wood Johnson has this interdisciplinary research leaders program where they bring kind of mid-career researchers from around the country together to try to understand how they can develop research approaches that get to the social determinants of health. And I've been one of the advisors, and I've been trying to encourage them to think about strategies that get at this idea of power and narrative, trying to study how narrative shapes policy. I mean, the best example that I can give you lots of examples, but one of the best examples that I think is just easiest to understand is you look at the current president, who said when he announced his candidacy, Mexicans are bringing drugs, they're bringing crime, they're rapists. That's a narrative. That's a story about who these people are, how they're different from us. And then that leads to policy, like separating children from families at the border, because these people are bringing crime, they're bringing drugs, they're rapists. They're not humans, they're not families. These aren't children who need their parents. So we can separate them at the border and put children in cages as a consequence. Children, living in cages, afraid, away from their parents, being bullied, the rest of it. And that's a perfect example of how this framework manifests itself, because we know that those children will have lifelong physical, emotional, health consequences as a result of having been separated from their parent and placed in a cage in a country in which they didn't even speak the language or understand the culture. So there are real consequences of narrative, and we should study narrative. Every every fascist dictator in the world recognizes the power of propaganda. If propaganda didn't have any influence, nobody would do it. But propaganda is essentially setting a narrative, telling a story of like who we are as a country. And that propaganda shapes policy, and that policy creates real world conditions. So we should be able to study that. We should be able to study how those influences operate and show how they have adverse effects on health, particularly for the populations that are being dehumanized. So I spent, a fair amount of time working with these researchers, trying to get them to grapple with these concepts, and they're interested. They just don't get the same kind of reward that you get at sort of academic institutions for publishing these sort of abstract studies on, sort of quantitative things that are very easy to count and easy to measure. So it's easier to sort of burnish your career with those kinds of studies than it is to do the kind of studies that require you to work with, a health researcher, to work with a political scientist or a sociologist or a psychologist to understand how these disciplines actually interrelate.
Thank you. Another question. One of the things that political progressives often point to as a solution to health in the US is a socialized system like they have in Canada or many other European countries that you discussed earlier. Based on the data that you've seen, if this was enacted in the US, would it make that big of a difference in people's health if the other social programming spending didn't increase as well?
Yeah, thanks for that question. It's a question I spent a lot of time grappling with. And I'll give you the short answer. The answer is universal health care alone won't solve health disparities. It won't even really come close. And when you look at systems like Kaiser or the VA, where people are, universally covered, you still have health disparities. And I'm not talking about access to health care disparities. I mean, you find some of those too, but those are usually reduced. But you have health disparities because health, as I showed you in that graphic, probably closer to 90% of what shapes people's health happens outside the doctor's office. So having access to the doctor's office will help you in that 10% of things that healthcare helps you with, but it won't help you in the 90%. I'll tell you what will help you in the 90%. It won't close that gap, but what it will help is the other side of the equation of universal healthcare, which is not the healthcare, it's the universal part. Universal programs create a sense of shared solidarity. Shared solidarity is what allows us to have an inclusive narrative. So it's this idea that you are seen and heard and valued by being a full-fledged member of society and eligible for this universal program that helps reduce stress and helps people think that if I get sick, this society has my back. And so I often say that the important part of that phrase universal coverage is not the coverage, it's the universal. And so if we really want to get at health disparities, we have to change the narrative about who belongs and how we're all inextricably connected. And if we can, I'm not talking about a fanciful world. I'm not saying Canada is a perfect country, but it's better than this one, a lot better when it comes to health. It has better health outcomes. It has flatter gradients, and people feel less stressed, in part because there's more universality. And many Western democracies have higher levels of social solidarity across populations, and therefore less allostatic load, free-floating allostatic load, which is what you have a lot of in the United States. So the issue is really, is universal health care important for the health care, or is it important for the social solidarity? And the answer is both. But I think that probably the more salient piece of it is the social solidarity.
Thank you, Dr. Iton. I could use a little social solidarity to reduce my allostatic load. So there is another question. Why is the life expectancy of Americans declining due to deaths of despair if the social narrative and policy are intrinsically in the white population's favor?
Yeah, and so I wrote an op-ed about this. It's called "How Racism is Killing White Americans," and not in the way that you think. And this is basically collateral damage. So the lack of social solidarity means that you lack things like universal health care, significant unemployment benefits, access to education for job retraining when essentially the economy changes, access to mental health services, things like some sort of housing subsidy for folks that aren't destined to make a lot of money. The ability to essentially still have that human right to be housed. Those kinds of things are fundamentally what is driving deaths of despair. So I talk about this sort of boomerang effect. When you have policy that's essentially designed to discriminate against mostly Black people, but other people of color in this country, it has this boomerang effect on white people, particularly poorly educated white people. They end up essentially suffering the consequences of the lack of social solidarity that's driven by racism. And so the collateral damage of racism is deaths of despair. And that's why you see white, and there are many, many, many more poor white people than there are poor Black people. And those poor white people are dying disproportionately of self-inflicted causes, alcohol, opiate overdose, and suicide, as a result of essentially seeing their grasp slip on the ladder of the American dream. And, I could show you other data from Raj Chetty, who looks at social and economic mobility in the United States, and he shows that the American dream is dead. If you want the American dream, you should move to Canada. It's twice as likely that, you will actually move from the lowest economic quintile to the highest economic quintile in Canada than in the United States. The chance of moving that way is about 6% in the United States. In Canada, it's somewhere closer to 15%. So the reality is that there's collateral damage. There's the boomerang effect. So the intent is to essentially steer resources away from Black people, disproportionately Black people, also Latinos and other populations that are, essentially, disfavored. And the effect is that you can't limit your damage to those populations, that there's collateral damage to populations that you ostensibly care about. And that's the irony of Trumpism, is that it's actually bad for the people that support him the most. If somebody's talking, I can't hear you.
Oh, I'm sorry. Can you also talk about a community participatory approach when investigating the importance of narrative? It seems if the researchers are outside of the community, there may be a perpetuation of othering. And how can we support the development of working in partnership and co-creating these research platforms?
Well, that's a complex question, meaning it has a lot of moving parts. So I'm going to try to answer it by just giving an example. In 1994 in California, there were a series of propositions, 186, 187. 187 was designed to deny benefits to undocumented Californians. And it was shepherded by, at the time, Governor Pete Wilson, who was running for his second term. And, it was designed to deny health benefits, deny education, deny a whole raft of social benefits to people who couldn't prove their, who didn't have documentation as American citizens and or legal residents. And in 2010 in California, so 1994 2010, we had Latino Speaker of the House, Latino Senate Pro Tem. We had legislation to allow for undocumented Californians to take the California bar, to take the medical exam, to get in-state tuition at UCs and in the medical schools and all state colleges, to get driver's licenses, and to decriminalize a whole host of status crimes associated with being undocumented, as well as a whole host of refusal to cooperate with the federal immigration authorities. So how did we go from 1994, where we wanted to take away the right for undocumented children to go to school, to 2010, where we passed all these policies, including full scope Medi-Cal coverage, that's California Medicaid, for undocumented children 0 to 18, which was recently expanded to include children all the way up to age 26. That there's still movement afoot now to include people over the age of 65, and then ultimately all undocumented Californians. How did you go to that from 1994, where we were trying to take away the ability for undocumented children to go to public elementary school? And the answer is narrative change. That's what happened in that period. And that was not just sort of by chance, it wasn't lucky, it was intentional. By investing in communities, developing narrative change capacity, and largely, crafting coordinated campaigns to change the way we talk about and think about undocumented Californians. And that required, as I said, when I showed you that slide about narrative of inclusion, the first thing that a narrative of inclusion does is it changes the narrator. And to that extent, it's a participatory process. It allows people to speak for themselves, to tell their own stories, to illustrate their humanity so that we see our shared humanity in them. And in order to do that, you have to build the capacity of communities to essentially control their own narrative about, who they are, how they got here, what they contribute, what kind of policies they prioritize. That's a process of building narrative change capacity within communities. You can't do this to communities. So, to the extent that, a participatory research processes can be utilized to essentially shift and build capacity in communities, that has happened in California and continues to happen. We don't necessarily call it, participatory research. We call it, essentially building power, both political power, social power. Social power, part of social power is narrative power, being able to control the story of how you came to be. That is a participatory process. There's no other way to do it. It's not about, imposing, a new narrative on populations. It's about that population owning that narrative and controlling it.
Okay, one last question. Thank you so much for bearing with us. We have quite a few more questions, but just time for one last one. The question is, how do we as collective members of healthcare and education institutions start to affect change? What is one thing that we could do as students, faculty, or staff?
Well, I think some of you are already doing that. Again, I mentioned that, you got to leverage your own credibility to essentially help shape the kind of policy that we want to see in our lives and for our children's lives. And so that means you got to take risks. There's just no other way about it. Abraham Kindi said to us the other day, he said, on one end, you've got sort of equity and social justice and racial justice. On the other end, you've got the status quo. And he said, in the middle between the status quo and racial justice, is the status quo. So there's no middle. You've got to move towards racial equity, and you've got to take the risk to create that racial equity. There's no sort of compromise that sort of gets you halfway, that's sort of half good. Everything between status quo and racial equity is status quo. So in order to get there, you have to change the status quo. You have to essentially disrupt the status quo. And that means, you know, at Touro University, where you see essentially institutional racism, assuming you do, you have to disrupt that. That means, you know, at the California Endowment, you have to disrupt that. And that's the story of this work. You know, if you see the status quo sort of replicating harm, you're part of that harm unless you're working actively to disrupt that status quo.
Thank you so much, Dr. Iton. We really appreciate you coming out for the second social justice speaker series of this session, of this series. And we also appreciate you coming out again since you spoke in 2017. This has been more than enlightening, and I think it gives our students and all of our viewers an opportunity to not only reflect, but opportunities to think about our own research and work and how we can affect change. Again, we really do appreciate you taking the time to meet with us and enlighten us and to give us a view into your research. So we're going to go ahead and end now. Thank you.
Thanks for having me.
Gail? You're muted.
I just want to reiterate what Professor Wilson is saying. We so appreciate your talk today. And again, it does give us more food for thought as we kind of move forward and try to follow the goals that you've outlined in hoping to make an impact on health equity in this country. Thank you again.
Thank you, and thank you for doing what you do.
All right, everyone, we're going to see you next time for our next series, which will be with Dr. Ruben Miller.